Blockchain for the interoperability of healthcare data. Said like that, it sounds awesome. But let's take a closer look to really see how things are. Hi, this is Fabio Ferentini. Welcome to Blockchain for Archer. Together with Greta, we've explored the potential uses of blockchain technology and distributed ledgers in the healthcare sector. Today we're going to take a closer look at one of these topics, the management of healthcare data, with a focus on interoperability, a word that's been heard a lot lately. You should know that as early as the 2010s, I'm talking around 2013 to 2014, there was already literature on this subject. And from about 2016 onwards, there was an explosion of articles on the topic. I started studying this topic around 2017, and I found myself faced with a truly significant amount of information. Equally significant is the number of projects, which later evolved into startups that serve as concrete examples. These startups have taken on the challenge of using this technology specifically for healthcare data management and have entered the market. That's why I say they represent a concrete example. In my opinion, it would be interesting to dedicate a video to this topic. The most commonly used blockchains for healthcare data management are Ethereum, which is public and permissionless, and Hyperledger Fabric, which is private and permissioned. There are also hybrid blockchains, but we'll look at those later on if necessary. Now, thank you. Hyperledger Fabric is part of the Hyperledger family. For those who aren't familiar with Hyperledger, it's enough to know that it's an open source project by the Linux Foundation, which provides the tools to create and manage private permission blockchains. There are various Hyperledger models, each with its own structure and specific purposes. For the record, I'll mention them to you. We have Hyperledger Besu, Hyperledger Burrow, Fabric, which in my opinion is perhaps the most widely used for managing healthcare data, Hyperledger Indy, Iroha, and Sawtooth. But what are the reasons why one of the most explored uses of blockchain in healthcare is the management of clinical data, particularly EHRs, electronic health records, that is, medical records? Because of its architecture and how it works, these reasons are basically four. First, data integrity, which does not necessarily mean that the data is correct or not, but rather that its cryptographic image has been created and recorded on the blockchain through a consensus mechanism. It is distributed and there it remains immutable. Let me explain better. 1 + 1 is an operation that, as a correct result, gives 2. Maybe a calculation error is made and 3 is written instead. A cryptographic image of 3 is created and recorded on the blockchain. It's clear that the result is wrong, that data is incorrect, but it is intact. That is, once its cryptographic image has been recorded on the blockchain, we will always know that this data can be traced back to that operation. That the result is wrong, that's another story, but the data is intact. Be careful, because regarding so-called data integrity, many organizations, several organizations have given precise definitions, all traceable to the acronym ALCOA+. In particular, I'm referring to the World Health Organization, the FDA, and the Medicines and Healthcare Products Regulatory Agency, that is, the regulatory agency for medicines and healthcare products in the United Kingdom. And what does ALCOA+ mean? It means attributable, legible, contemporaneous, original, and accurate. The plus was then added because other characteristics were identified. Maybe there will be a video about this because it's an extremely important concept, the so-called data integrity. The traceability of the data, because it's always possible to trace its origin, that is, from which visit, analysis, or instrumental exam it was generated. This is a crucial aspect because even today it still happens, and perhaps not even that infrequently, that data is collected by various entities. For example, let's take a public entity and a private entity, each in their own silos, and there's absolutely no guarantee that they communicate with each other. So what happens is that this patient might go from the public entity to the private one, interacting with clinicians who, however, do not have access to their complete medical history because the two silos do not communicate with each other. And so what happens? It happens that the patient is always forced to carry around their folder of tests and medical records. It is hoped that with the new Electronic Health Record 2.0, this impasse can be overcome. Third, data ownership. If, with the PNRR, there is more and more talk about putting the patient at the center, ideally we should be the owners, the holders of our health data, and decide who to grant access to. Be careful, because this concept is not just a whim, not at all. Rather, it is closely linked to the concept of portability of health data. That is, the possibility for citizens, and indeed the right, to transfer their health data from one provider to another. And obviously the data must be in a format that allows for this transfer. The portability of health data was established by Article 20 of the well-known European law on the General Data Protection Regulation, or GDPR. Fourth, finally we come to the well-known interoperability of data. Recently, thanks again to the PNRR, the Electronic Health Record 2.0, and the future EHDS, that is the European Health Data Space, there is more and more talk about interoperability. This consists in the ability of the information systems of various organizations, that is, wherever the data is produced, to exchange and share health information about patients, even though these systems are different from one another. To ensure interoperability, it is necessary to use appropriate information standards. One of these, perhaps the most widely used and certainly one of the best known, is HL7 FHIR, where FHIR stands for Fast Healthcare Interoperability Resources, that is, interoperable resources for rapid healthcare, while HL7 is the organization responsible for the exchange, integration, and sharing of health data. To get a clearer idea, let's look at a practical example of how this works. Blockchain technology promotes interoperability between two different entities, without the need for them to directly integrate their electronic health record management infrastructures. Blockchain replaces the intermediary that ensures trust between the two parties, thus performing a process of disintermediation and facilitating the exchange of information in a secure and efficient way. Mrs. Maria is the protagonist of today's example, a 75-year-old woman. With a complicated medical history, she frequently has to move between public hospital A and private clinic B for specific clinical treatments. Therefore, her data is distributed between A and B, which have two completely different clinical management systems that do not communicate with each other. So Maria, when she goes from A to B and vice versa, always has to carry all her medical documentation with her. However, sometimes there can be delays in updating the data, or there might even be issues caused by incomplete information in these records. There could even be incompatibilities in the data formats. Let's see how blockchain solves this kind of problem. So it's important to clarify one thing right away. Maria's sensitive data is not stored on the blockchain. What is stored is the cryptographic hash, meaning the cryptographic function of this data as well as the metadata. We'll see what those are in a moment. When Maria goes to hospital A for her checkup, visit, exam, or whatever it may be, her records are updated accordingly. Her medical record, her health data, are stored on a server belonging to hospital A. To ensure the integrity of the data and allow it to be verified by Clinic B when Maria goes there, Hospital A generates a cryptographic hash of Maria's clinical data and records it on the blockchain. The hash is a unique string of characters produced by a cryptographic algorithm, in this case applied to Maria's medical record and clinical data. For the record, I'll mention them to you. The cryptographic algorithm used for the Ethereum blockchain is KEKAK 256, later called SHA-3, while for Hyperledger Fabric it is SHA-256. Therefore, the hash represents the cryptographic image solely and exclusively of Maria's clinical information, and it is not possible to trace back to the original clinical data, the starting data. Furthermore, once the hash is recorded on the blockchain, it can no longer be modified. So, to put it simply, we can say that it is immutable. On the blockchain, Hospital A also records the metadata. What are these? For example, the timestamp, that is the date and time when the data was recorded. On the blockchain, the reference to the data, which is generally a URL, that is where the data has been stored, in this case on Hospital A's server. Information about the author, meaning who entered the data. For example, it could be a doctor, a nurse, or even a pharmacist. Because if Mrs. Maria were to go through the direct distribution at Hospital A, in that case the author would be a pharmacist. And finally, the type of data, that is whether we are dealing with images, diagnoses, test results, and so on. Can you also hash the metadata? Absolutely yes, if you want the immutability of the metadata as well. What's important to point out is that it's not advisable to create a single hash, that is, of both clinical data and metadata together, but rather to keep them separate. A few days later, Mrs. Maria needs to go to Clinic B for a checkup. And the doctors at Clinic B need to read the updated information in Mrs. Maria's medical record made by Hospital A. Therefore, Mrs. Maria grants access, again via blockchain, to the doctor or doctors at Clinic B, exactly as if it were a cryptocurrency transaction. In fact, in this case, asymmetric key cryptography or public-private key cryptography is being used. To give you a very simplified idea, it's as if the public key represents the email address. The private key, on the other hand, is the password, which allows you to read the emails associated with that account. The consent to data access provided by Mrs. Maria can also be recorded on the blockchain. In this case, it ensures even greater transparency. And it also allows Mrs. Maria to control who has access to her data. So Clinic B uses the reference present in the metadata to access the system data of Hospital A. Once obtained, the software allows the operator at Clinic B to calculate the hash of those data. And if it matches the hash registered on the blockchain by Hospital A, bingo, the two hashes match, the two sets of data match. So the integrity of the data is ensured. After that, Clinic B will integrate the verified data into its own system. And then they will proceed to update Mrs. Maria's medical record. And at this point, they will generate its hash to be registered on the blockchain. This hash will subsequently be available for verification by an operator from any institution. Therefore, thanks to the blockchain, we have verification of data integrity, its traceability, and data ownership, with which Mrs. Maria grants access to her own medical record. Thank you to an operator. And this is recorded on the blockchain. And all of this is part of what is called the interoperability of health data between two entities that, in theory, do not communicate with each other, do not exchange information, and have different ways of managing medical records. It is clear that, as I said before, what plays an absolutely decisive role in this interoperability is the format in which that data is stored. And earlier I mentioned FireHL7 as an example, but are there others as well? Exactly. This becomes crucial because if the data format standard is different, it's clear that interoperability cannot exist. However, FireHL7 is not the only one. There are also alternatives, such as OpenAIR, in which structures called archetypes play an extremely important role. In any case, we'll set these topics aside because they're not the focus of this channel. And above all, they're extremely complicated. We'll leave them to the industry experts. At this point, we need to ask the crucial question: does it make sense to use blockchain technology or distributed ledgers for managing healthcare data? And if so, does it improve interoperability that much? As you can see, the question is quite clear and straightforward in its formulation. First of all, I need to specify that what I just described is a major simplification of the various processes and dynamics. This was done to make them as digestible as possible, clearly at the expense of technical purity. But I hope those who are extremely knowledgeable will forgive me. My goal is to explain to users who are quite unfamiliar with this technology how certain dynamics work. Going back to the question, yes, it does make sense. This is demonstrated by the vast amount of studies published in scientific journals, where significant efforts have also been made from the perspective of startups and therefore businesses to use blockchain technology or distributed ledgers for managing health data for all the reasons that were mentioned at the beginning of the video, and therefore also as an improvement in interoperability. However, there is a caveat that leads to some rather significant clarifications which absolutely cannot be overlooked. What I am referring to is the fact that health data is extremely sensitive and valuable. Therefore, its management presents certain critical issues, first and foremost those related to privacy. And consequently, these processes must, in a certain sense, comply with the GDPR in Europe and with what is called HIPAA in the United States, where HIPAA stands for Health Insurance Portability and Accountability Act. In fact, there are new professional roles, usually legal experts, who possess cross-disciplinary skills in various fields, namely healthcare law, technology, and privacy. Without these professionals, there is a risk that a project could fail before it even gets off the ground, simply because it does not comply with regulatory requirements. And in fact, this is exactly the point. There are regulatory frameworks and possible sub-frameworks that are well defined and clearly outlined. And we are in a situation where it is not the regulations that adapt to technology, but exactly the opposite. Technology must comply with what the regulations dictate, and this obviously has consequences. The most classic example is that since we're talking about blockchain technology and distributed ledger technologies, the fact is that projects involving the management of health data tend to use DLTs rather than public permissionless blockchains, because decentralization has been sacrificed. In other words, they opted for greater compliance with regulations by using DLTs, even though this meant less decentralization, since DLTs made it easier to comply with what the law required. There is also another rather important issue for which DLTs, and private permission blockchains were chosen over public permissionless blockchains, especially in the early years. Now things are changing a bit, at least when it comes to projects involving the management of health data, and that is the issue of scalability. An impressive amount of health data is produced, so DLTs or private permission blockchains are needed to ensure truly significant scalability, something that public permissionless blockchains did not always guarantee. In the next video, I'll tell you about some startups and projects that have ventured into the market using this technology for managing health data, also to show you just how lively this sector is. As for the bibliography, you can find it in the video description. Thank you. Thank you for staying with me and listening until now. If you're interested in the channel, if these topics interest you, subscribe to the Blockchain for Healthcare channel and see you next time. Goodbye.